So we welcome everyone here this morning to the Haiti Health Network webinar. Today, I'm just really excited about the panelists we have today. It's a really great expertise in this area to share. We are definitely recording this as well because we want to be able to share it even after today in other contexts with other physicians, particularly in Haiti as well. So we thank everyone here for joining us today as we begin our discussion. Before we get started, just a little bit about the Haiti Health Network. Dr. Kaplan, as most of you know, has done a ton in the Cap-Haitian area to start connectivity. I'm with the Dalton Foundation, and that's been one of my passions after living and working in Haiti for a lot of years. Just the siloing that occurred was really breaking my heart, and just knowing that we could do so much more if we started to connect. So that's kind of where the heart came behind the Haiti Health Network in general. And we're constantly, I think Ted is the master at it, of connecting people to each other, and I'm learning from Ted, but we're constantly just trying to connect everybody in the context we see and seeing if we can help advance the work. The foundation that I work for, we do support some of the work that we end up finding and connecting. We can't support everything, but we do have some targeted projects as well that we support in Haiti. Here's a little overview of who we have with us today. Like I said, I was really excited for this panelist lineup that I'll give Dr. Kaplan the credit for putting together. So Dr. Kaplan will be one of the moderators today and help us out. Dr. Andrews, if he's able to join from his very busy practice, he's running a lab, which everyone knows right now, labs are very busy. He will help moderate and ask some questions as well, because he's been involved with this work in Haiti. We have Dr. Natasha Archer with us from the Boston Children's Cancer and Blood Disorders Center to share with us about her work. Dr. Ophelia Alvarez from the University of Miami School of Medicine, also joining us. And the Save One Life Foundation has been doing some great work all over the world with hemophilia. We have Lori Kelly and Chris Bombardier with us from that foundation to share about their work and what they're trying to accomplish in Haiti. And then we'll also have Ms. Valentine Joseph joining us from the JJ Foundation to share with us the work they are doing in Haiti, and also just some of her experiences that have gotten her involved. And as always, one of our goals is, even for the panelists and everybody on the call, to just be connected to each other, be aware of each other's work, and be able to find ways to connect and work together. So that's definitely our theme. You'll hear throughout everything we do. So for the process of the webinar, just really quickly, we will have the panelists share just a few minutes, 5 to 10-ish, depending on the situation, minutes about their work, both here in the US and how it relates to Haiti. That will be followed by a few questions, either by the participants on the webinar or by some of our moderators, to just prompt the discussion. And then after we finish having everybody present, we will then begin asking more questions, because there's always questions and points that come up as more speakers present. So then we will even have the panelists discussing among themselves at the end. If you are a participant and listening, we just ask that you will submit a question via the Q&A feature versus the chat. We're going to try to monitor both, but it is easier for us if the questions come in via the Q&A section. And we'll try to get to all of them. If we miss any, we'll follow up after the webinar and get them answered as best as we can. And then real quick, I just want to make everybody aware of the Haiti Health Network website that launched. That's going to be a couple months ago now, so it's still fairly new. But we encourage everybody to join the Haiti Health Network, participate in the Facebook group and the discussions that happen there, and then participate in all the educational activities we have. I will say the network is also actually getting involved in some very practical projects now of connecting people to resources throughout the COVID, with procuring PPE, helping get it distributed in different regions, doing some different things with medical equipment and supplies. So education is always going to be a main focus, but we're also switching into helping with some of the operational support as well, when and where we can. There's also a resource tool on the website to locate resources in Haiti. It's grouped by department and then even villages within the department where you can search for all different kinds of healthcare resources in Haiti. So just know that that is there and please use it. And if your organization's not on there, let me know, and shame on me. It should be on there and we'll get it on there. We do have a place also to post your events. You can see you can join the health network, you can join one of our specialty groups, or you can post an event to the site. So our goal is to get as many events posted on here that we can all share and be aware of all the things going on. And then my last thing, and before I turn it over to you, Dr. Kaplan, is just a reminder, we have been pretty active with supporting the community around COVID and Corona in Haiti. We've been hosting calls now. I think we're going on our 8th week, Ted, which is kind of a lot. We've been doing this every Monday night at 6:30, getting people from all over the country on to talk about what's being done in each department, how to share resources, and all that. So we would invite you, if you haven't already, to join those calls as well. Any information that can be added to that is good. And every week, I'll let Ted answer too, but I think it's getting richer and richer every week. We're hearing from on the ground physicians on the front lines, sharing best practices, and we're hearing from almost every region in Haiti. So it's been pretty valuable. I think we would stop doing if it wasn't valuable, but I don't feel like we're stopping it anytime soon. So we'll keep that going. There's information about that. So Ted, I'll turn it over to you about the order of which you think everyone should present, and we'll go from there.
All right, thank you, and welcome to our panelists and our participants today. I'm glad to see you all were able to join us. And we're trying to continue what we started before COVID started with, we were already having trouble getting to Haiti and continuing some of the conferences that we had begun to have in 2018. But we felt like this new video conferencing capabilities that at that point were becoming more and now ubiquitously used could allow us to not only continue but maybe even enhance and be more consistent and frequent in meeting and getting to our ultimate goal of everybody being aware of what everybody else is doing and working together when it's possible to accomplish more. And one of those topics that was we've been working in the CAP Patient Health Network for quite a while with Lori, and has been these specialty issues in hematology. We weren't aware in the north of anything happening with sickle cell until the last few years. And when we discovered that, we were very excited, and it has spread to other parts of the country. Kind of to polar opposites within hematology as far as Haiti goes. You have one fairly rare condition in Haiti, but you know, very challenging to deal with, more so because it's rare. And then sickle cell disease, which is quite common. And we know that there's many patients with sickle cell disease or anemia falciparum in Haiti that nobody has ever diagnosed. I know when I was doing a lot of mobile clinics, every once in a while someone would show up with sickle cell crisis and nobody really knew what to do. As far as the family, the local clinic, or wherever you would try to refer them to, they didn't have much to work with either. So I think that's improved a little bit over the years, but still a long way to go. So with that, well, I'm going to turn it over first to Valentine Joseph from the JJ Foundation, just to give us a little bit of a set the scene as far as this important condition of sickle cell disease in Haiti from her standpoint. And then we have two of the doctors, Dr. Alvarez and Dr. Archer, who have put so much effort into advancing where we were to where we are now as far as sickle cell disease. So Valentine, please.
Hello, good morning. Thank you so much for the invitation to be here with you guys. I'm very happy to see that everyone is doing well, and hopefully that will be the case in Haiti. I am Valentine Joseph. I am the founder and president of JJ Foundation for Women and Children. founded in 2014 in memories of my three brothers who all died from sickle cell disease in Haiti. And my only child, my daughter, who is now 27, also has the disease. I have a nephew with the disease. So as you can tell, it's definitely very prominent in my family. So that being said, we know all the how would I call it, disadvantages when you have sickle cell disease. So as I watch my daughter grow up and becoming, she earned her master's, she's doing her PhD. I felt the need to really get in front of this disease, especially in Haiti, and also here to advocate. It's not that because you're diagnosed with sickle cell that it's a life sentence anymore. So these kids can thrive, and they have thrived, and keep pushing for new drugs, new treatments. So it was in that aspect that I decided to found the foundation. I have been going to Haiti for the past 4 years, and I am currently funding um, 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 medication, drugs, and whatever else for 3 kids in Haiti. Also, we are launching a Haiti sickle cell initiative in the Grandance Jérémy region, for those of you who are familiar with Haiti. Um, and this is with my partner, Bob Downey, who is with Global Health Teams. And also one of the people that have also been guiding us is Dr. Alvarez, whom I love, who's here with us. And basically, because of everything that's going on now with Corona, it's just everything has stopped. There's nothing happening right now. But I'm eager to start. I'm eager. What we will be doing is providing funding for testing and also treatment for, we're hoping maybe 1,000 people. So with that being said, if you guys have any questions, I'll be more than happy to answer. We do a gala every year in Palm Beach County, and I also go to Haiti every December. We also do other work in Saint Louis du Sud, which is also in the southern part of Haiti. I am hoping once the initial initiative is successful, we can definitely expand to either the capital and other places that we deem vital and necessary.
Okay. I don't see any questions on right yet, but I did want to see if you could just take a minute or two to share with us the experience you had with your brothers that were in Haiti having this.
Sure. Unfortunately, my brother, my first brother, my eldest, my parents' first kid, was
Condition and
Jean Evans. He died, and of course, I was not born yet. And however, the second one, Anderson, I did not know either. But Yoldi, I did know Yoldi because Yoldi came after me. And I remember vividly, I am 4 years older than him, or, at the time. And he died in my arms in Saint Louis du Sud. And I guess it's very fitting that I am going back to do that. Here I was, a 10-year-old kid, and with a brother having fever, shivering, swollen joints, and moaning, groaning. I remember it vividly, and fever, very hot, and it was a Friday evening. And I remember we were sitting at my grandmother's house, and of course the talk was, it's voodoo, because nobody understood it. Imagine it's like 40 years ago. So whenever a child was sick, it's something that had to do with voodoo. And basically it didn't dawn on me. He passed away in my arms. It was very painful. And then I moved to New York, and we never heard of that word, sickle cell disease, or anemia falciform as it is known in Haiti. So when my daughter, no, before my daughter was born, after high school, I did not even know I have the trait myself. I went through a very tough time after trying to do 3 years in high school instead of 4. So a lot of studying. Then I became very I used to have headaches. And I went to my primary care physician, who happened to be a friend of the family. And he somehow did a test. He came back, he's like, "Are you aware you have sickle cell trait?" I'm like, "What is that?" And I was 18 years old in New York City. And he started talking to me about, make sure when you date someone that he doesn't have the trait as well. I was like, okay, what is he talking about? I knew nothing about it. So we went on. I was engaged at the time. I went home, I did not even ask. And then I think it was a casual, how would I call it? Casual talk. And my fiance then, my ex-husband, he's like, "Oh, I think they told me I had that too when I was in Haiti." I'm like, "Uh?" So again, we were getting ready to get married, happy times. And we got married. And all I could think of was, hopefully, I've been a good girl, I've been a good kid, nothing's gonna happen. Well, after my daughter was born, 2 weeks later, I got a call from Dr. Perlman, which changed my life. And Kimberly was diagnosed with sickle cell. And I was scared, very scared. I was only 23 years old. And at the time, we didn't have the internet like we have here today. There were no specialists. And I just kept on forging. Thankfully for me, I used to work for MetLife on Wall Street. And again, MetLife at the time was the top insurance company. So I would go to see the pediatrician. I remember Dr. Feldman, who used to be at Cornell. He was the top specialist with sickle cell. And every time I went to a pediatrician, they kept on telling me that I have to see Dr. Feldman. Well, Dr. Feldman used to charge $250 for a visit. I could not afford it. So it became very scary. And I went to my general manager, because I was an administrator at MetLife, and I, told him the difficulties I was having. And Dr. Feldman says that the money that MetLife was giving him at the time did not suffice. So long story short, CEO got back to us, and they gave Dr. Feldman a contract. I was this was like a lifesaver for me. And he saw Kimberly. Right then and there, he gave Kimberly the Pneumovax at 6 months. And things got better. And then when Kimberly was 4, I was told that the warm weather would be better. I packed up in 1 month, moved down to Florida. So to go back to my brother, until I saw Kimberly exhibiting the same symptoms, little joints. I'm like, what's going on? And then after digging, more digging, it was definitely what it was. And then my mom telling me stories about my other brothers, exactly the same. They all died from sickle cell. And then my little cousin in New York, again, went through it. He died in New York. Then my nephew, he's not doing as well as Kimberly is doing. But again, I kept on staying in front of the disease. And I think that's what's the key. You keep on staying in front of it. Don't be reactive to it. You have to be proactive. And I've been blessed. Kimberly I remember when the schools kept on telling me to put her into a 509, she's missing school. I kept on fighting and wanted her to have a normal life. Then she went to college, then she went to graduate school. And today she's doing her PhD. These are the stories. And that's the reason we have to keep on telling those stories. These kids can thrive. And it's up to each one of us to keep on pushing them, to keep on pushing for fairness. One of the things that I'm noticing, Dr. Kaplan, is that as adults, there's a new fight. There's a new obstacle. They're not being understood. I have gone to, let's say, Jupiter Medical Center in Palm Beach County. They don't know how to treat the disease. And here I am. I'm not a medical person. and I have to tell them, push my daughter with 6 milligram of morphine, 500 cc, of IV, blah, blah, blah. Give her some Benadryl, and they're looking at me. It's like, are you a nurse? No, I'm not. Blah, blah, blah. And then they said, what do we do next? I'm like, okay, I want to see her hemoglobin, counts, hematocrit counts. And they're all looking at me. And then I'm like, okay, she's good. We're ready to go home. Rock and rolling. So yeah, this is the story. And my goal is to eventually, especially in Haiti, I mean, kids should not be dying of this disease anymore. That's the goal. It's not a dream. I want to see this a reality. Dr. Alvarez has been doing great work there, and I think once we put all our how would I call it, strength and capacities together, we will definitely do better by these kids. We have to.
Well, thank you. That's a great start to what we're going to be talking about in the first half with sickle cell. We have two Dr. A's that specialize in sickle cell. I'm going to let in slightly alphabetical order, Dr. Ophelia Alvarez go next, and I think the two of them are working together in many things, so you can kind of split up what you want to say, but please tell us what you guys are doing. Someone has already asked a question. Is there a screening in Haiti? So that was a good softball to get us started with talking about what we're doing with sickle cell in Haiti.
Can you see my screen?
Yes.
Yes.
Okay, good. Okay, so first I want to tell you about the first thing that I did. And I have been doing work, but in the setting of research, because I wanted to get as organized and as objective as possible in my work. And I started probably around 2015, getting to know some of the key people there, like Dr. Jean Florival in Port-au-Prince, who was a sickle cell doctor. Fortunately, he died shortly after I met him, and after the first time I visited Haiti. And then getting the group together. And this resulted in the publication that you see there that was published in Pediatrics last year. Newborn screening for sickle cell disease using point of care testing and low income setting. So we chose to work with the University of Justinian Hospital in Cap-Haïtien because we actually have links with that hospital with the family medicine program at the University of Miami. Then basically we instituted a newborn screening program, and what you see in the top is Callie Hustis, nurse practitioner, works with me, and the lab technician that we have at the time to do isolective focusing methodology to screen the babies. And here we have one of the nurses, newborn screening nurses in the maternity ward. And basically we use combined methodology. At the beginning, we were screening the children with isolated focusing alone for the first 3 months. And then we used the combination of a point of care sickle scan that give you the result in 5 minutes with the IEF methodology. And this is the project summary. So we have the hypothesis that the rapid point of care will be reliable in Haiti and will assist newborn screening. One of the issues is that when you have just the regular laboratory testing, there is a delay between knowing, checking the baby and getting the result. It could be a week, could be more than a week. And the problem was that sometimes you cannot reach the family. So that's why we thought, having this point of care done at the birthing unit may be good. But we wanted to validate the test for newborn screening, which wasn't done at that time. This work was conducted between August of 2017 and August of 2018 for 1 year. So in order to validate that, we also send the cards to the Florida Newborn Screening Laboratory in Jacksonville. And that was compared, the results by HPLC were compared to the IF testing and the point of care. And we wanted specifically to look at the specificity and sensitivity of the point of care device. So this is the figure that we have in the publication. So we screened over 2,000 children. And you see on the left, the children that were trade. So we found around 14% they have sickle cell trait, and 3.5% they have C trait. And then the children who have disease with a hemoglobin C, we were not able to confirm anybody. I mean, we tested them, but they were not, they did not basically have the confirmatory testing that was C. But with the SS, SC, and the S-beta thalassemia plus, we had 81% of them actually were SS. And 5 were SC, and none of the ones that showed the SA were actually that. I think they were trait, but not SA. So it was a lot of implementation, you know, to create the laboratory and the resources and all that. We still sustaining the program with 2 employees right now, a community health worker and a nurse, because we're following the children that we diagnosed, which were about 18 children. So the results of the study are summarized here. 1.48% of the children screened positive for sickle cell. The specificity and sensitivity were great. And the fact that we used the rapid testing increased the confirmatory testing rate significantly. The result was the incidence that we found was 0.83%, which actually is higher than what was previously reported from St. Damien Hospital, which was reported in the literature in the year 2013. At that time, they reported 0.58%. Of course, could be variable, you know, wherever the children are. Maybe there are more children in Cap-Haitien than they are in Port-au-Prince in terms of the testing. But the rapid testing made us start the penicillin earlier, incorporate the children to the clinic much earlier, and give the Prevnar that we were paying on time. Right now, as I mentioned, I have continued to support the program with the money that I have left from this gift that I received, but I was able to secure an NIH grant for the implementation of newborn screening and follow-up of the children. And that started in 2019, so we are at the end of year 1 right now. And we have been concentrated in the preparatory phase, which is kind of a humongous work. So we have 4 sites. We have St. Damien, which is the only children's hospital in Haiti, which is located in Tabar, the Hospital General in Port-au-Prince, and also the Université Justinian in Cap-Haitien and Sacré-Cœur in Milo. So these are the 4 sites. And the study has 3 aims. The first aim is to look at the relative incidence of sickle cell disease among newborns in Miami, actually. So the first aim is in Miami. We are trying to compare or prove that babies that are born from Haitian families have more likely sickle cell than the African Americans. And this is based on the percentage that I found over there, which is higher than what we have among African Americans. And this is a prospective and a retrospective study of the children who were, they are referred to us for confirmatory testing. Then the second aim is the newborn screening implementation in Haiti in these 4 sites. The St. Damien Hospital have been implementing newborn screening already fortunately for us in Justinian, I was not pleased with the work that the laboratory technician was doing, so I let him off. So we are hiring a new person that needs to be trained. But with the COVID-19 circumstances, it's really difficult, especially if we need to send that person outside of the country. And then the last aim is a follow-up of the children, and also implementing TCD in the children. And we are going to be training the examiners here in Miami once the travel bans are over. So we're going to start the work in Saint Damian in about a week. We already have done the site initiation visit, which we did by Zoom. And we are going to be sending them today the hydroxyurea and the penicillin for them to be able to work with that. Now, I think you have mentioned, I think Barbara had mentioned about resources that we need and how we can network and things like that. Right, Barbara? This is something you want me to comment on?
Yeah, that would be wonderful.
Okay. So there are three things that I think are very important, and I'm sure that Natasha maybe will agree with that. But one of the, and I don't know how much you can help, but I mean, these are things that if I have like a wish list, I will put it in the wish list. First is to know more about the capacity in Haiti for materials. And of course we can, talk to the sites and they will tell us what they have, and some of the sites have more than other. But to be able to have very organized ideas of where to get the materials, the price of the materials, and things like that, so they will be self-sufficient. And some of the sites are more self-sufficient than other sites. Mm-hmm. So that's one thing. The other thing is the limitations that we have in most of the hospitals that I work on for microbiology. I mean, microbiology is very important because obviously the children could have infections. I mean, that's the killer number one. We are mitigating that by putting them on penicillin and giving them immunizations. But if they have a fever and we do a blood culture, not all the hospitals have microbiology capability. So that is a very important resource that we're lacking in Haiti. And lastly, instead of me sending the penicillin, oral penicillin, because they have IM, but instead of me sending the oral penicillin and the hydroxyurea, it would be ideal if we can convince somewhere, an industry in Haiti for that to produce these medications. Because then it's not me or Natasha or whoever, or Valentin, send the medication, but they will be able to basically write the prescription and give it to the patient. So these are the three things that I think that are very, very important for as resource. And I will stop here.
Thank you. I'm going to give a couple quick responses since you asked the questions, and then I don't want to get too bogged down into it before we move on to the next speaker. But so related to materials, we do have the Relink Global Health.org directory, which will show you not the quantities, but where things are available for sale in Haiti, including drug companies. We do have a couple that work with the network, and we could have further talk about that. We know that Dr. DeGennaro, who's also been involved with the lab in Justinian for cancer, and I think maybe microbiology, he is also importing medications, and he probably could get.
Yeah, I have spoken with him a long, long time ago, and I don't know what happened.
He's got a company now that's importing medications, I think.
Oh, yeah.
From India, so you can.
Okay. Yeah. Well, I actually using the University of Miami. I mean, I'm purchasing at the University of Miami, so with a low cost. So I don't know that
might be lower cost. and your employee discount from it's coming
Yeah.
from India. It's a whole
Yeah. Yeah.
factor less.
Yeah.
And it's in bulk and regular deliveries and so forth.
Mhm.
And what was about the domestic domestic production? I guess we do have those companies in Haiti that you could try to talk to about it if we get the numbers up. That goes back to the identification. Dr. Andrews, you want to have any comments or questions about the technical aspects related to those tests and what they were finding with sickle cell disease? Dr. Andrews is a pathologist at the University of Miami in charge of the laboratory.
Am I on?
Yes, we can hear you.
Okay, very good. Yes, so no, I don't have any comments actually. I actually was not I'm not involved in any of the laboratory efforts. That I have to say it's impressive what Dr. Alvarez has pulled off. I mean, I think having been involved, so my background for those of, I think Lori Kelly is the only one that knows my relationship with Haiti. I'm sort of the opposite story to Dr. Alvarez. I was actually very involved for several years, a lot of time and effort and heartache and a lot of things that people experience when they work in Haiti shortly after the earthquake, and was involved with setting up a laboratory through an affiliation with Project Metashare, Dr. Green and all of those people in Port-au-Prince at Bernard Mebs Hospital, the General Services Laboratory, to provide some ongoing general laboratory results of all kinds, microbiology being a challenge, by the way. We had so I continued that for a few years and actually developed a medical technologist training program, which had a short-lived lifespan. But in the last few years, I really have not been as involved. I'm really more of a listener here, not a, I don't have a lot to contribute. My engagement with Haiti has been an attempt with Lori Kelly and others to try and set up a platform, a laboratory-based platform for diagnosing hemophilia. And I won't speak for Lori, but I know that a key element to developing the infrastructure for getting Haiti established as a site that merits a distribution of concentrate is to have laboratory testing capacity. And we tried to do this, and so I had some industry sponsors, and we were about ready to gear up for it, and then there was some civil unrest, and so we backed off. And so that's been in my engagement, is to try, not sickle cell anemia, but to help establish a platform for coagulation testing that could diagnose hemophilia. I might add, it's several orders of magnitude more difficult. There are no point of care tests, at least at this point. I could probably develop one, but there aren't any, and they wouldn't be sufficient anyway for actually diagnosing mild, moderate, or severe hemophilia. So that's my story. I've been involved, and I help out. I've helped with Ted. Every once in a while, he has a case or two that needs some testing, and we get samples to Miami, and we do the factor levels here. But again, I'm just much more of a listener than a panelist. So I'll stop there.
We'll circle back to that process a little later. So let's move. Let's turn it over to Dr. Archer to add some more to the story from her standpoint related to sickle cell in Haiti.
Great. Can everybody hear me okay?
Yes.
Great. So I just wanted to thank Dr. Kaplan and Barbara Campbell for holding this webinar and for inviting me to speak about my experience with sickle cell disease in Haiti. I don't really have much more to add, I think, than what Dr. Alvarez has already wonderfully presented, but can talk a little bit about my experience. Ms. Joseph, I haven't met you yet, so it's wonderful to be on this call with you, and I want to thank you for sharing everything that you did about your personal experiences as well as what you're currently doing. It would be wonderful to I think, work with you in the future. And I think at least when it comes to that goal of this webinar, I hope we can really work together. Most of the work that I've done has, when it comes to hematology in Haiti, has focused on the sickle cell disease population. And I've mostly worked with Partners in Health, or Zami La Santé, in the Central Plateau. We've mostly focused on a hospital-based program, meaning at the L'Hôpital Université de Mirebalais, that we have tried to set up hospital-based newborn screening to look for sickle cell disease within our neonates, as well as symptom-based screening for kids as well as adults who present with any sort of symptoms or complications associated with sickle cell disease. In terms of, Dr. Alvarez already mentioned that she saw a relatively high prevalence of sickle cell disease in the Haitian population that she tested in the north, and previous testing done in Port-au-Prince saw also high levels of 6 per 1,000 babies with sickle cell disease. Babies born in Haiti having sickle cell disease. Despite that, no national newborn screening exists. And so the focus of everything that we've done is tried to improve that, because we know that early intervention, either early management of symptoms or preventative therapies like penicillin, or immunizations, and even hydroxyurea at approximately 1 year from 1 year of age and up could be helpful. So our goals have really focused on that screening and diagnosis, then the provision of routine therapies like the penicillin, immunization, and hydroxyurea. We've also done early management of symptoms, where we've educated individuals with sickle cell disease about things to watch out for, and community health workers, and what we can do and what they should be doing, and encouraging those with sickle cell disease to do if they have those symptoms. In terms of acute complications, we serve as a resource to clinicians who work in the hospitals to talk about outpatients and inpatients, provide, and in the hospitals, they provide supportive care, pain management, and luckily we have access to blood transfusions when needed. Most of our work has really stopped since 2018. We really have had a lot of difficulty going back to Haiti and to continue, following our patients. And now with COVID-19, I think it's going to be even more challenging. So what I'd love to really discuss on this call is how we could all support each other during this time, and kind of pool our efforts together so that we could start to better follow all patients with sickle cell disease that are currently in the country. That's all I really have. I'm happy to answer any questions.
I think that was a perfect point to end on. Thank you. Go ahead, Ted. Go ahead.
We don't have any questions from the viewers so far, but I did have a couple for either of the two hematologists. What has been your impressions up to this point of the care that is given when a patient in a crisis or with a problem comes to, let's say the best hospitals in Haiti before we pick on the less best ones? Do they have the proper knowledge of what to do? Are they able to manage those patients reasonably well, or is there a big educational and training effort that happen?
I'm going to start first, although I think Natasha has more the vision of being there more time. I think that the knowledge that they have is okay. Especially the pediatricians. These are all pediatricians who are handling the patients. And for instance, in Saint Demian, they have very good knowledge. I have been there and I know pretty much the resources that they have. I think the main limitation is the blood transfusion, very limited. I have been, like Natasha mentioned, resource for them. So they call me in WhatsApp, or they text me regarding questions. And for instance, patients who had a stroke, or patients who had spleen sequestration, the need for splenectomy. So there are some questions that they come through, and of course, many of these things require blood transfusions. So the family are the ones who have to donate the transfusion. The transfusion is not immediately available. I understand Dr. Archer said that they may have better resources over there. So there are a lot of limitations for the care, although the knowledge may be there. But of course, they need, they have questions that we should be that kind of resource to them. Certainly Zoom is an opportunity for clinics, or telemedicine, maybe an opportunity. And as part of what I'm going to be doing, we are going to be using that resource, like a consultation for cases that they have questions. Now, some of the other hospitals may be more limited, but I have been impressed that despite the limitations, by the way, one of the limitations is testing also. Some of the sites have patients who may have trade, but they have done, they have maybe done some testing, and maybe the testing is not correct. So there is a lot of limitation with laboratory testing overall, and resources. But in terms of pain management, I think they are okay. But of course, could be improved.
I'd love to add to that, and that I think we all could learn how to better care for our sickle cell disease patients, and I include myself in that. I think there's a lot that we can do, but I also feel that there's a lot that we can do better. Pain is the most common presenting complication in sickle cell disease. And even in Boston, in the United States, we treat pain with opioids. And, this is which is good for decreasing the pain, but it's not necessarily what you would want to be on long-term. It's also, it has a number of different side effects. Yeah, it's definitely the best that we can do right now, but it warrants more research and us just trying to find other solutions. We're also, I think that Ms. Joseph talked about getting ahead of sickle cell disease, so always trying to be ahead of sickle cell disease. And right now, unfortunately, clinicians in Haiti can only be reactive, it seems, because what they have the resources for is to react to once somebody gets a fever, to treat, to maybe treat that fever. Once somebody has pain, to treat that pain. We don't have that. We have one great option, I guess, right now in the United States, which is hydroxyurea, which has helped many people, but it doesn't, but it's not widely available in Haiti. Also, that medication, as good as it is, has not been perfect for all patients. And so we just definitely just need more options and more research into this. So while I think that I agree that I feel that my Haitian colleagues are excellent clinicians, but it's almost as if we're you know, they're at a significant disadvantage because they have to be reactive, that they don't have all the resources as Dr. Alvarez outlined. I think, again, you know, up until very recently, we weren't always diagnosing individuals with sickle cell disease. And so that does make it a little bit more difficult for anybody who's in training to recognize what it is at the moment that they present. I've been exceptionally, though, impressed with my colleagues and the fact that they're able to do so despite maybe not having had, you know, a patient that they've definitively treated with sickle cell disease.
I was going to add something to that. I think that y'all's points are exactly right on the reactive part. And when I was living in Haiti, we had an excellent Haitian physician at our clinic that educated herself immensely on sickle cell. And we had 3 patients that we took care of on a regular basis at our clinic. And just watching the way that they reacted was amazing, and caring for the patients. We always seemed to find a way to scrounge to get the hydroxyurea they needed. And then we had a system set up for blood transfusions when someone needed one. We'd get the brigade together. We'd all go down to the Red Cross in Port-au-Prince and we'd donate the blood to make sure that our patient got it. And we were committed to those 3 patients. And I think that's why I'm really excited about this conversation, is because through coordination, through what I'm hearing you guys say with the testing, what's going through my mind, and I will follow up on these supply issues and how we can make that work for them easier, so that instead of being able to take care of 3, they can take care of more and spread that around and get some coordinated effort. I think we can start to see some impact. And then, like you said, Dr. Archer, just as here in the US, hopefully we're seeing some more of that cutting edge research and stuff, opportunities for that to bring in new ideas that can be then shared with those in Haiti. Because while they do have to react in Haiti, I was really impressed with how they did react. I was really impressed, and how they sustained it over time was really impressive. We had 3 sickle cell patients in their 30s that were doing pretty well considering what they had to deal with, and these were pretty bad cases too. So just wanted to add that, and like I said, my excitement on the collaboration so that we can make it easier going forward.
If I can add, I think way before I founded the foundation, I was approached by a sickle cell kid whose parent have lost a child already to sickle cell. And basically I was able, they had visas. They came here. I made arrangement for him to see Kimberly's doctor, Dr. Gowda in Palm Beach. And when I heard of the treatment he was getting in Haiti, having a lot of crisis and having lost his brother, and of course the parents were devastated. And we changed, Dr. Gowda made the change, and I followed up. We sent, he was still getting penicillin shots, and the kid was at the time, give or take, I think he was 16, 17. And which I was told, this is not a regular protocol. So long story short, this kid right now is in medical school. Mm-hmm. Crises have been diminished by, I mean, he's living a normal life. Then 2 years ago, during my mission, 2018, December, again, the little girl, Nia, going to the hospital every 3 months. So with the foundation, we've been following up, again, making sure she has her meds. And of course, Dr. Alvarez is the one who's been assisting me. Kid has not had a crisis. So this is what gives me courage and give me hope that one by one, I know the numbers are not huge, but it's one by one. And I am hoping that with this new initiative and with the work that Dr. Alvarez is doing, and yes, I think it's about time that we knock on the political doors and said, hey, there's a problem here, people. You know, I remember when HIV came to Haiti, yes, it was killing people. They took initiative. Yes, we're not at that level, but these are little kids who are suffering, and the suffering is tremendous. And there's something we can do about it. So I see here from this panel, I think if we put all our resources together, and definitely, I knock on doors. Trust me, I'm not, this is one thing I do. I'm not afraid. We were supposed to do a mission, medical mission with Dr. Alvarez and about 15 other doctors. Unfortunately, I think what's creating issues and obstacles for us is this unrest all the time in Haiti. We don't have the foundations or everything else in order, and then you keep on having these things. It keeps on setting you back, and people are afraid to even start something. And I know none of us here can do anything about it, but I think that's where the frustration, and I myself don't know how. It's like right now, I am ready. We have the funding to do this, you know, and the money's just sitting in my account while kids are dying. I don't know what to do, you know. And then you had COVID. This is the frustration. And, you know, I worked so hard into getting it to that point. Now it is, and I'm ready to rock and roll. I can't. And like the other day, this kid that we've been funding, her medication is almost done. I don't know how I'm gonna send the medication now. So God forbid I hear that she's in the hospital. That's gonna break my heart. So these are the issues, but definitely I think for what we have, one case by one case, we can definitely make a huge difference in these in this sickle cell, you know, I don't know, crisis. It's yeah, I don't sleep at night.
Challenge. I think if we hadn't already known, which we did, the last couple of years have certainly brought into greater focus how important it is to equip people on the ground in Haiti to do as much as possible, and we've had to do that quite a bit in the Haiti Health Network as far as our own operations. And so that's, you know, as Dr. Andrews was stating, many of us have had our hearts broken and disappointed, and you know, it's not easy, but now we're at a point where we really have no other choice, if, at least in the short term, but to identify and fortify those people on the ground that could do something for us. And we do, and we're mentioned there, St. Damien's and Mirabelet Hospital and Milo Hospital definitely are three that function quite well with or without foreign intervention all the time. Let's go ahead and switch over to our other disease and hematology today, and we'll start with Lori to introduce us about hemophilia and in Haiti and in general in the third world, what a big challenge that is. And then at the end, we'll have some general discussion about everything.
Thank you, Ted. I'd also like to note that Chris Bombardier will be joining me in this presentation as well. He's the executive director of Save One Life, and I'm the founder and current president. I have an adult son with hemophilia who's 32, and Chris actually has hemophilia. So he joined us a year ago, January, but he's been on our board for quite a number of years, and also has done hemophilia testing in Western Africa, but I'll let him talk about that. I know we had slides. I don't know if we're going to go through those slides.
You can share your screen, Lori. Go ahead.
Oh, yeah, you don't have our slides. Chris, you have the slides. Thanks. I'll just go ahead and present while we're getting those ready. So I while we were talking, and we may have different disease states, but we are so connected. The issues are all the same. And I have to say, it's been a long, torturous, difficult road, but I've picked up all of you along the way somehow. And I'm trying to remember, like, when did I meet Ted? When did I meet Natasha? Natasha, I heard about you from your cousin in Ohio, like 10 years ago, and you're working at the hospital where my son was born. So it's amazing how we get so connected. And David, you work with the doctor that I know, and she recommended you to me. And we met in Boston a few years ago, had a great meeting. And David has really downplayed his role. He helped us get a few boys diagnosed, which was absolutely the key to opening the door to our program in Haiti. So thank you for that. And then Barbara, you and I had a very dashing and exciting less than 24 hours in Haiti a year ago, February.
Yes, we did.
James Bond novel or something. It was crazy. But I want to start by quoting the book Mountains Beyond Mountains, because I started my work globally in hemophilia in 1996. And probably 2000 is when I read that book. And it just struck me that all the philosophy I had developed along the way, Paul Farmer was reinforcing. And I just thought, I'm on the right track. We call it Save One Life because Tracy Kidder quoted Paul as saying, if I saved one patient in my whole life, that wouldn't be too bad. And that's our philosophy, is that there are other organizations like the World Federation of Hemophilia in Montreal that looks at the big picture, the 400,000 who have hemophilia globally, the 200 something countries. You know, they look at all the big numbers, they work with the health ministries. Meanwhile, I noticed the people at the bottom were being left behind and are still being left behind. So they do great work, the World Federation, and someone needs to do that, but somebody also needs to help the family struggling at the bottom, and that's where we come in. We believe that working one person at a time has value, and it's shown it. So our focus is on the individual, our focus is on supporting them financially and with medicine, and getting them on their feet. And then eventually, with the World Federation coming in at a top down and us coming in at a bottom level, we'll close the gap, as they call it, in care and meet in the middle where people will have the resources that they need. So we, part of our specialty is going into countries where there's no infrastructure at all for hemophilia. And we've adopted that as one of our missions. And the World Federation loves it because we go in and do all the groundwork. And when we eventually have some kind of an infrastructure in place, we invite the World Federation to come in, and they are the big guns. They have research money, they have physician training, nurse training, physiotherapy, laboratory diagnostics. The possibilities are endless, and there is funding, but they won't come in unless there's an infrastructure. And that's been what we're trying to do. I've been working in Haiti since 2002. It's been a long road, but I will not quit. I won't give up. So our mission is there. I can't actually read it because I don't have it memorized, but because of the photos on the page. But that is our mission, to help people with bleeding disorders, including von Willebrand disease, in developing countries, and to help them on a one-to-one basis. Next slide, Chris. Founded by me in 2001. And again, I have an adult son with hemophilia. He's doing great. And then Chris, why don't you introduce yourself?
Yeah, so I'm Chris Bombardier, the new executive director of Save One Life. I started in January of last year. I myself have hemophilia. I have severe hemophilia B. And I have been serving on the board for Save One Life since 2012. And my interest in helping with hemophilia in developing countries kind of spurred from my previous work, which was in a research lab at the University of Colorado doing hemophilia research. And I had an opportunity to travel to Kenya to help set up an established diagnostic lab there. And it just really opened my eyes and my perspective on what hemophilia looks like without access to care. You know, by looking at me, you would probably never know I have hemophilia, and then seeing what it looks like without that access to care was pretty eye-opening. So throughout that journey, I got involved with Save One Life and actually started a journey to climb the 7 summits, which are the highest mountain on every continent, to raise awareness for Save One Life and raise funds for Save One Life. And I completed that journey in 2018 and then got the opportunity to work for Save One Life. I'm also earning my master's in global health from Northwestern University right now. So just trying to finish that up, which is exciting. But I'm really honored to be a part of Save One Life and work to help people with hemophilia around the world, which is really cool.
Yep. And as you can see, we are based in Groveland, Massachusetts. We have a staff of 6, and we work currently with 53 program partners in 14 developing countries. So we are very small, but we are growing. And despite the pandemic, we continue to solicit for funds and try to get support. We do get some support from pharmaceutical companies, but we are in between a rock and a hard place. We're based in the US, but we work globally, so we qualify for nothing. You either have to be located overseas to get global funding or serve people in the US to get US funding. So we're struggling to find the funding, but so far, everything's been working great. Having Chris come on board has been fantastic. It's brought us to a whole new level. And he is as excited as I am about working in Haiti. And I've dealt with going there in 2002. There were kidnappings the year following that. Then there was the earthquake. And then, of course, Barbara and I went a year ago, February. There was incredible upheaval. We had a very exciting ride to the airport to leave the country, and we felt terrible about leaving. And I'm waiting for the moment when I can go back, because we've established a lot of connections. And David, I think David and I don't know, David, I think you and I might be the only ones from the hemophilia community to have actually gone to Haiti. I think that'd be a fair statement. I don't know of anybody else from our community that I know of who has been. Next slide, Chris.
Yeah.
Chris, you want to go present our programs?
Yeah, so this is essentially just an overview of what we do at Save One Life. So our main program that was a kind of the founding program is a child sponsorship program. And since 2001, we've supported over 2,000 children in developing countries through this child sponsorship program. And we currently have over 1,400 beneficiaries currently enrolled in the program. And that's throughout the 14 countries where we work. We also provide educational scholarships to individuals with bleeding disorders as a way for them to gain independence financially and hopefully establish a career, considering most of them are fairly disabled by a young age. And we've given 176 students support through that program since 2012. We also have a program that's focused on microenterprise grants to help families or individuals with bleeding disorders start small businesses to kind of work better with their limitations caused by their bleeding disorder. We've also helped fund 39 summer camps, which are great ways for children and young adults with bleeding disorders to get together, learn from each other about their condition, feel connected, and build community. And then Project Share is a program that we helped donate blood clotting medication around the world. So we were able to get blood clotting factor or medication from people in the US that can no longer use their product for many different reasons. And we fulfill requests from people in countries that don't have access to medication. And since that program started in 2002, we've shipped over 150 million units to 79 different countries, which is really exciting.
Yeah, and if you know about the cost of factor, which some of you do, that represents probably about $160 million worth of factor, and it's a lot. It's a lot for a small group of people to be shipping, but they're very successful.
Yeah.
So, all right. So that's kind of an overview of our programs. So the experience with Haiti, I first went in 2002, and how it happened. Well, first of all, my background. I think my best friend in high school, college is African American. I worked in a community with many Haitian people here in Boston and just got to know them and really liked them. And then I attended my first global hemophilia meeting in Ireland in 1996. And out of the 2,000 attendees, I was absolutely shocked to see one African American, or, you know, basically one Black person. And it just shocked me that Sub-Saharan Africa and the Caribbean were not being represented at the world meeting. And in fairness to WFH, they were kind of, even though they've existed for about 30 years, they were still very young and new as an NGO and had a long way to go. They are now really like a world-class organization. And because of my work, I believe because of my work in Africa, I've gone in, I was the first person to go into many of the countries in Africa, Sub-Saharan Africa. and then invited them to come in to meet the leaders that we found and to see the infrastructure we built. They are now taking up the initiative, and they've done some fantastic work in Africa. It's really been great. However, the Caribbean is still very ignored. So we are, they've focused a bit on the Spanish-speaking Caribbean and not the non-Spanish speaking. And so we're really working hard to help increase our presence there. Jamaica, Haiti, Dominican Republic is the first country I ever visited for my work back in 1998. And they've become lifelong friends. And so it's very easy for me to get to Haiti if I go to Dominican Republic, obviously. So in 2002, there was a pastor who visited America who was looking for medicine, and I couldn't donate it to him because I knew nothing about Haiti. And that's what spurred my interest. And I said, I've got to go and check it out and see what the story is there. And I met some great people that might be leaders. I actually formed a board of directors. We were ready to go, and then it all fell apart due to a lot of kidnappings, and everything just shut down. In fact, one of the girls, a lady I met on the plane ride going down there, owned her own art studio in just outside of Port-au-Prince, very well-to-do. And we had breakfast that Friday morning, and the night before, her best friend's father was shot in the head by one of the thugs from the slums. So she was literally shaking, and it just wasn't the right time, but we kept going. We kept picking up more people interested in Haiti. I have like 4 pages of people interested in helping in Haiti. So we're finally coming together. In 2012, I think, Ted, it was long after I met you, and you recommended going to Cap Haitian and visiting with your contacts there. And so I did, and it was just a fantastic visit. I met the first boy, Mitch, who has hemophilia, and met with him, went to Jacques Assil to see him, and met some more contacts, and then again had all these great plans, couldn't materialize. But Mitch disappeared for a while, but now we found him again. And then the last visit was with Barbara, 2019, and connected with Coastal Haiti Mission, and that was finally the key. So thankfully, through this network, we've met Coastal Haiti Mission, and they have agreed to be our program partner in Haiti. And we've met 2 half-brothers who have hemophilia. Thanks to David, he got them tested. He also got, I think, Mitch tested, and James Lee out in the West, who we have not enrolled in the program yet. And if we go to the next slide, Chris, here are the boys, the 2 half-brothers, and Luvens and Stevens, and they became our first beneficiaries to be enrolled in Haiti. This program has become the first official hemophilia program in Haiti, I think, as far as I know. So we're very excited to say that we've started it. Now the pandemic has slowed us down, of course, but the boys have sponsors here in the US, and we have more people lined up. And we've put together a registry of known patients. We do need to get people in Port-au-Prince to help us find them. We haven't been in touch with them for a while. So kind of in keeping with how we've been doing this, our wish list would be to get that patient registry confirmed, location, names, and then get the patients diagnosed somehow. David really helped us out with that, but we can't always rely on people carting blood back to Miami in their pockets. Not that David did that, but other people did. And we want to get patients diagnosed. We want to educate the midwives, the rural healthcare workers, so that they're aware of symptoms and they can report back and maybe have them at least checked out symptomatically, if not clinically. And then we need couriers to bring the medicine, to Haiti. We've had people that we know have returned to Haiti before the pandemic, and we would ship medicine to them and they would bring it into the country and then deliver it to our contacts there. Of course, we'd love to visit. We made a major breakthrough in having Partners in Health agree to be our medical partners in Haiti. And so they would like to be kind of the main center for handling the hemophilia cases. And that's really key. Our model is such that you have to have a registry of patients, and you have to have a hospital that's committed to accepting the medicine for the patients, to distributing the medicine, to diagnosing the patients, and keeping that patient registry. And then work in a more, rather than a central but more distributed way to the rural regions, work with the clinics there. But we have to get that one main hospital and a physician who's committed, and then a patient leader eventually, and that's going to be hard. But that's all down the road. I think right now we're still happy with our very first, even though it's limited success, and it's a good omen for things to come. Chris, you want to add anything?
No, I think you covered it really well. But yeah, we're very excited to start at least making some progress towards this goal that you've had for so long. And yeah, it's exciting.
And I want to thank all of you, especially Ted, for all your support and help through the years. It's, you know, it's been a long haul, but it's going to be worth it. Even if it's just these two boys forever, it's still worth it.
May I ask a couple of questions?
Please.
Sure.
The coastal Haiti mission, how did you get involved with them, and what is their primary focus?
We got involved with them again through a very networked way. June Levinson, who I think you know,
Yeah.
and
Yep.
she knows Paul and the whole gang. Oh my gosh, how did I get connected with her? I can't even remember. Maybe it was through this network, but we got connected, and she was very adamant. You've got to talk to this person. You got to, you know, she said we should talk to you. And I kept thinking, I know that name sounds familiar because of your cousin. So yeah, and June was the one who she saw, actually, she got the mission newsletter a couple of years ago, and she saw a photo of the boys, and she said, that's got to be hemophilia. The boys were not diagnosed. And just from the photo and the description, she suspected it. We got the boys' blood, we got them diagnosed in Miami, and that's what opened that door.
And are they currently getting all of the factor to the boys now?
Yes, well, we
Okay.
have shipped up until now, because of COVID, it's getting extremely difficult to ship medicine in, but we have been shipping medicine to Dr. I can't remember, Ali Joseph, Dr. Ali Joseph, and then his brother, Cody Joseph, is the pastor. So the boys live right near the pastor and the doctor, and luckily they've been able to inject them. In fact, one of the boys, Stevens, wasn't even walking, and now he's walking again.
Oh, okay, great. Okay.
So basically, they're a local support
Yeah.
organization for that community, which happens to have 2 of the 4 patients, and the third one is not far from there also. So it's been sort of a convenience thing, and they're very responsive organization there that people have a lot of trust in. But you know, as we go into a national situation, you know, that's where Mirabelais Hospital and Partners in Health is going to be more and more important to coordinate, reach out. I think there's a lot of lack of knowledge about hemophilia throughout the country, so that's something that we need to strategize on how to improve.
I just wanted to emphasize the like this social support organization with the work of the hospital. I just think that it's a really good partnership of having somebody who's almost like a liaison between the patients and their medical care. You know, community health workers serve a similar, but actually having an organization with resources that can serve as that connector is actually I think a phenomenal partnership. So I think that's that it would be great to sort of capitalize our work to establishing that in different areas as well.
Lori, I have 3 questions, and I may have missed the first one that I'm going to ask you, okay? But it seems like everything is clinical diagnosis, I guess, because of hemarthrosis, and then you send the blood to David, and David make the diagnosis. But and I don't know that. That's what I'm asking you. Are they able to do PTs and PTTs over there?
I don't think so.
I think
Because, I
some
mean,
labs are, but
that would be the basics that you have, right? So you have a PTT of 60 or 100 or something like that. You're going to suspect the patient has either hemophilia A or hemophilia B. And then the question is the other labs. But you have to have basic screening of PT, PTT, that they are reliable.
Hospital University of Mirabelais has been trying to actually establish that. I remember on our last call, we were working to assess the machine in the laboratory and whether or not we could use that for regular screening. I know that there was a donated machine. It wasn't It wasn't being regularly used at the time. David, I'm not sure if you were involved in any of that.
Yeah, it's quite, I mean, you're talking about it in Mirebalais?
Yes.
Yeah,
Exactly.
I had for several years indirect knowledge, and it's been a couple of years since I've been involved. But I mean, here's a classic Haiti story. We actually acquired two reasonably small footprint coagulation instruments donated by a major manufacturer, and shipped them down to Haiti, and they vanished, they evaporated, never made it to their source. And by the way, there are probably laboratories that can do a PT and a PTT test in Haiti. I don't know at this moment. I mean, it's been a couple of years since I've been involved in that laboratory. I don't know if they are right now.
David, we obviously have abandoned bleeding time, but is that a possibility for von Willebrand that bleeding time can be done?
Yeah, I mean, I'm not a big advocate of the bleeding time, but.
Yeah, but I mean, they have nothing. I mean, they cannot test for von Willebrand. So that would be a crude screening test.
Yeah.
Okay, the other question that I have is, if we find a patient, how can we refer the patient to you? And the last question is, you said you use people to take the factor over there. Can you just use DHL as the way of sending the factor?
We have, yes, we've been using
okay.
FedEx, DHL, it works. But during this time of pandemic, I sent out 3 shipments in one day, and they all got hung up in customs. They all got released eventually, but they got hung up. So they're scrutinizing the shipments more and more, and you've got to have more and more paperwork. It's a different world.
But that's good to hear, because I'm planning to send one today.
Okay.
Not factor, but medication.
Let me know in the future.
What is the technical requirements with the factor for all this listening to know if we're trying to send it or carry it or so forth? How long does it how long can it stay outside of refrigeration?
Well, it has to be refrigerated. You have to send it refrigerated.
No, you don't. You don't. We don't. The World Federation doesn't even send it refrigerated because it would be exorbitant costs. So all of the factor, if you read the labels, they are now saying room temperature is fine. And we know from experience, I've been shipping factor since 1996. And I mean, you name the place, it's gone there. Christmas Island. I don't even know where that is hardly. We've shipped it all over, and it's gotten there. Wherever FedEx goes, it'll go. And we've never had a problem with any shipment ever. It's been kept in customs for a week, not refrigerated. It's been on cargo planes. It's been in people's cars. As long as the integrity of the bottle is not breached by extreme temperatures, the factor should be fine. It may lose effectiveness by sitting there, but it's not going to be much. So we have no problem with shipping it.
And keeping it in those patients' homes or the local clinic that may or may not have refrigeration is not been a problem either, right?
Right. Usually we instruct patients to, if they don't have refrigeration, to keep it in a very cool, dark place just to keep the temperature down. But most of the people we ship to do have refrigeration. And if they don't, we buy it for them. I've bought refrigerators for gypsies, the Roma out in the Carpathian Mountains. I bought refrigerator, I can't even remember. We've bought refrigerators for a lot of people. As long as they have electricity and they can have a small fridge, then we can ship them factor to store, just as a precaution. It also keeps it clean.
Do we have other questions or comments about hemophilia? I have a few questions left over about sickle cell disease, and then we can go to a general discussion. There was a question, we sort of answered it, but just if anybody knows, I don't really have a specific answer about places in each department that can adequately diagnose and treat sickle cell disease. Dr. Alvarez has 4 hospitals that she's working with in her study, which doesn't necessarily, this same as that answer, but anybody aware of other hospitals besides St. Damien, Justinian Milo, and University Hospital that has any kind of special abilities in testing and treating sickle cell disease?
Global health teams in the southern part, which is Jeremy, they do have a lab and they've been doing the testing for a while now with global health team in the south, Jeremy particularly. And those are,
They're all the way in, Jeremy?
yes, not in Port-au-Prince. Yeah.
Okay. I knew they were in Grand Anse, but I thought maybe they were a
Well,
little.
Gondance is it's part of that, Jeremy. Yeah, it's there.
Other question we had was, and I guess, I think the more large the hospital, the better they can do, but I
The
don't know.
Hospital University of Mirabelais is also can do some testing. We've recently acquired the point of care testing that Dr. Alvarez mentioned in her talk, and so, but it all depends on we haven't been doing that testing on people who are not symptomatic, and we focused our isoelectric focusing testing on newborns. So it really just depends on the situation, which is why I wouldn't do a blanketed, anybody can come around and just get their sickle cell disease tests. I think the problem with that is that we are going to be doing tons of several tests and potentially wasting some resources, because you don't really need multiple tests to once you diagnose, you diagnose. And so that's why there's a little bit of caution there. And then maybe what we really need to do is actually learn from Save One Life's work and think about sort of this idea of actually having some registry information so that we're not repeating the same test and not getting that out to other individuals.
Do you not have a registry from the newborn screening?
We don't have a registry that's up to date. And, it's, as I said, we've had a lot of difficulty getting back in touch with a lot of our patients really since 2018. So we don't know exactly what's happening when it comes to their symptoms, how many of them have succumbed to the disease, or sort of what their general outcomes have been. They also, even in light of sort of this COVID-19, we don't know exactly how our patients are doing. When we know with COVID-19, individuals with sickle cell disease can have devastating outcomes.
Okay, that's kind of a follow-up related question was about the nuts and bolts and challenges of managing hydroxyurea in Haiti. Does it need any special handling? We mentioned
Thanks.
about getting it there and so forth.
Thanks. I tried to answer that in the chat, but mostly what I've done is have used a standard dose of 20 milligrams per kilogram and have rounded that up based on the capsule size. Mostly I focused on using the capsules, which can be opened up, sprinkled, and put into water and taken that way. And then when it comes to follow-up, if the individual is on hydroxyurea, I've actually done every 3 months, every month for the first 3 months, and then every 3 months for subsequently for labs, physical exam, and education. Dr. Alvarez, because she's on an NIH study, might have something more standardized that has to be followed, but I have found that sufficient with following my patients, especially if I'm not doing any dose escalation.
Well, I think for the patient who had a stroke, the idea will be that we should escalate, but that will be obviously require more teaching, the physicians how to do that. The other thing that I have been instructing the pediatricians is to prepare the hydroxyurea suspension or solution for the younger ones. And they can, these hospitals are able to prepare it So it will be a matter of just giving the, the recipe for the pharmacist to prepare. So that's
Yeah.
another alternative.
I think that would be great. The only issue I've had with that is that the distribution of that would require at least from what I've seen, has required patients to come back and forth to the hospital
every month.
If you give the
Yeah.
capsules, then you could have up to 3 months, in between the visits, which I think it makes it a little bit more manageable. What we've done is actually coupled any visits with an education sort of seminar where we've done education for the group. We've been able to, support their transportation because we only have them come, 2 to 4 times a year. And that kind of helps in terms of limiting the amount of time that people have to get away from work. It also helps in terms of, supporting them in terms of the transportation. And then it also kind of, I think it makes it worth their while in terms of the kids, because they get a little swag or a little gift, when they come during that time. And then it just, I think generally makes it a little bit easier. I apologize that I have to actually get off the webinar for another call.
Yeah.
But I think this has really been great, and I'd love to stay in touch with the people on the call. So I hope maybe Barbara Campbell could facilitate that, maybe get us all our information.
Some notes about ways that we can try to, just the idea, like you said, of having, you have to have the medical facility as a partner, and then you have to have the facilitator. It's a non-for-profit or whatever that looks like, and trying to get that set up for sickle cell in Haiti. I think that there are some connections that can be made to help foster that, even despite the conditions we're in now. Like as Ted shared, we've been able to surprisingly do a lot with the unrest and COVID with our amazing staff on the ground. And so anyway, I say that just to bring hope, that I think we can still do a lot despite the circumstances that we can't control. And I thank you all for being here. I don't know, some of us can stay longer if you want, but for those I know have a 1 o'clock deadline, please jump off. But thank you guys so much.
Before you go, have you ever talked with St. Boniface, Haiti? Because they're in Boston and they're in the South. That's another regional leader.
Yes, I've had a lot of conversations with them, and we are very close to actually setting something up for sickle cell disease.
Good.
I have to go also, but thank you so much, and please send us this global health directory. Okay.
One thing I think
details, and I will highlight what you're looking for the searches so you can see it. I will follow up and send that to you.
Okay, thank you.
A national registry for sickle cell. I think JJ Foundation is definitely interested in that. Definitely.
I think if you could get maybe a patient or some other highly motivated person to be a coordinator on the ground, that would make a lot of would help in going around different areas and looking for patients and then keeping them in a centralized registry. And maybe they can also look for hemophilia patients while they're at it.
If you guys visit my website, one of the things we just did, and I am trying to partner with a group of individuals in the southern section. They have their own group. They've been doing a lot of outreach, and they're educated young guys and ladies. I think there's a doctor in the group as well. And JJ was able to fund a COVID-19 outreach. If you go on the website, you'll see the pictures. I was so amazed. There were about 20 to 30 people going to villages with masks, t-shirt identifying themselves, and then providing buckets, providing soap. I mean, it was so successful. I'm trying to work with them right now on the ground and to see how JJ can partner with them. And I think this registry might be something that we can talk to them about. Also just spreading the word about sickle cell. So we have a few things on the pipeline, just that the country has to be open. And maybe I'll speak with Lori as well in how she set up the registry and take it from there. We certainly have the technology here. So we'll see how that, that goes. I'm excited about that.
And you can please invite or yourself or those people doing the COVID thing to join our Monday night meetings and
Yeah,
learn.
unfortunately, we don't speak English. Oh, no, one of them does. The vice president does speak English. Okay.
We have Creole translation on there. It's okay. We welcome it. So it's okay.
We have a few people that can translate.
Yeah.
It was a pleasure, guys. This was so exciting. Yeah, definitely. I am excited. We have to do something together. I think with all our resources, we can definitely be successful.
I had one other question that maybe would have been nice the doctors were still here, but I'd be interested, especially in Valentine, your response to this about genetic counseling, genetic testing, trying to, give people that knowledge that you didn't quite have when you were starting your family. What are your thoughts about that? And it also, has a aspect with hemophilia.
I have been asked that question many times. I think, to be honest, going back, I don't think I would have made a different choice. I was given the choice. I had my doctors who sat me down and gave me options of either having an amnio to find out. I don't think I would have changed it. I think it's a personal decision, case by case, and no regrets at all. I think, look where I am here today. Now, I think sickle cell right now, it's one of those diseases. I mean, there may not be a full cure right now, but it's manageable. And what I went through, I think, made me a better person, and I would not change that for anything. I would not change that for anything at all. And like Laurie said, one life at a time. I said, going into this, I only have to change one life going into this. If I can save one kid in Haiti from having a good life, going to school, be successful with sickle cell, then my mission has been accomplished. Yeah, one.
What do you think, Lori? Any thoughts about that?
Yeah, she's making me laugh because I remember telling my husband, now my ex-husband, in '94, just let me adopt one baby from Rwanda from the massacre. I will be happy the rest of my life. And he said no. And now I have 1,400 kids. So I always think back to that it really, if you feel like you can help one person in this life, it's critical. It's worthwhile, no matter. And I know Paul had a great example in Mountains Beyond Mountains of the amount of money they spent for one Haitian patient, I think, to Miami. And he was criticized roundly for it because people tend to look at the dollar per capita, blah, 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 and all that. We don't operate that way. We focus on the individual. And one by one, it's a difficult road. It's a very difficult road to take. It's not the norm, but that's what we chose. And I feel it's really valuable.
Especially in Haiti, I think the needs are so vast. You can get overwhelmed. And I have been asked, why did I go into the South? And I'm like, okay, my parents are from there. I was born in Port-au-Prince, but it starts home. So let me see what I can do from home. I go home first with the limited resources that I have. Let me help home first. And then look at this. We expanded into Jeremy. I've never been to Jeremy, by the way. Okay. So yeah, I think it's not a question of everything has to be done in Port-au-Prince. I think people have this idea. It's like everything has to be done in Port-au-Prince. No, as a matter of fact, when you go in the outskirts and the rural places, I think you might find better results because these people, they are more appreciative. I think in one of the things, and as a Haitian, I'm not afraid to say it, you go into Port-au-Prince and you're from the US. It's as if like we had a gold pot, we're putting our hands into it, okay? They don't know the hours. Look at us now. I think each one of us could have been someplace else, doing something else, or the work that I have to put to do the asking during my gala of, and then just to go back. And what am I doing? I have no family members in Haiti, especially except for like cousins, no uncles. my mom, my parents, everyone is in New York. Why am I doing it? But they have this idea in Port-au-Prince. It's like, you know what, hey, another foundation, NGO coming, blah, 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 let's take, they have the money. And I don't subscribe that. I mean, the people who are helping me, they're not even my family. They're really my friends. You're either going to believe in what I'm going to do, you're going to support me. And I appreciate that. So every dollar you give me, I have to be responsible with it. And when I can, I can. I cannot solve all of Haiti's problem. This is what I'm doing. This is the focus. I'm not going to venture into anything. I started doing the scholarship, which I want to do. But currently, I looked at the numbers and I look at the feedback I was getting. I stopped it. It made no sense. If I am going to fund 26 children and I'm paying with donors' money and I cannot get with the director every month, what's the use? I need results. I need to understand, because if a donor calls and asks me, how are those children? What am I going to say? I don't have the answer. So I had to stop. I mean, I want to do it, but it has to be done correctly. So but Haiti, I have seen the change. And when I look at you guys who are not Haitian doing this, who am I not to keep on pushing? I'm grateful. I mean, I'm truly grateful. If it wasn't for you guys, I think Haiti would have been in worse shape than it is today. So I am thankful and grateful and appreciate all of you.
Thank you.
Also, they have a term in sports, pick each other up.
Yes.
And you know, some people that are struggling or things haven't gone well recently or at certain points, we can pick each other up and keep the progress moving forward as we're working together. So that's why I believe so much in what we're doing with the network. So I want to thank everybody for joining, and we'll continue the collaboration and the communications over this issue. I'm hoping that that there are good synergies between the hemophilia and sickle cell issues that will improve both the results for both. And you know, we have a big job still, even in sickle cell and definitely hemophilia, of awareness throughout the country and the medical community, so that the Haiti Health Network stands as one place that if we keep putting information there, it will remind people. Eventually, they'll get it that these things are out there, and there's these approaches at this point that we can use to try to address them.
Yes, that's a great point, Ted. And just to add on, if there's information that you guys feel is valuable to publish, please put it on the Haiti Health Network site. We can even do some different things to highlight it in our different venues, but that's one easy way we can help expand education. I mean, there's much more organized ways and create awareness that we could look into doing, but that's a very easy, free thing that we could do right now. So if there is, please send that out.
Thank you. Thanks to both of you, Barbara and Ted. It's great knowing you, Ted. I can't even remember how long we've known each other, maybe 15 years. I don't know. It just seems like forever, and it's been great. So I'm really looking forward to the future.
Yeah, thank you all for taking the time to be here. I know everyone is so busy, so we really appreciate your time. And I think the webinar is very valuable for the people on it. We'll also share it, and it can be valuable going forward in the recorded version, because there's just a lot of great information to share. So we'll be sharing it widely. So thank you all.
Stay safe.
Hey,
Yes,
have a
thank
wonderful
you.
weekend, everybody.
Bye-bye.
Bye-bye.
Bye.
Bye.